All right, thanks everyone. Please take a seat. We'll get started, not to fall behind too much. So the next session will be a panel discussion. So there are no presentations, no research has been done on this yet. So this is really just the current crisis of this year, where U.S. government has suddenly pulled its support. And the only bit of analysis that has been done is what Brendan is prepared. So he will be introducing the session, and after that, it'll just be a discussion of country experiences around this work. So let's just get started right away. To Brendan.
Thanks, Lola, and I'll try and buy some time from the last session. So, I think to start the last session, this is a bit different from the last session. So I'll try to talk to the what. Last session was different system transition, not a progress transition not being an end. So I talked to the what and the what is the part of sustainability, then a bit of the effect on the cuts, and lead to the action which shapes the design. So in terms of the what, I think it's important to take on the definition that came through sustainable financing in terms of what sustainability is. So we don't transition. Transition say we're supposed to work towards sustainability. So the first we ensure is sustainable and predictable resources. Ensure they are actually used, aligning partnerships, and support the sustainable. That's part of the broader sustainable financing. What? Now, what are the best transition and why it's especially better? So here I'm trying to show to them. So there's a planned transition. So planned transition. Yeah, sign some. Yeah, sign the kind of thing. Leaders say that the planned transition. And planned transition is very so that's part of the important context as well. Now, if we try and look at what are some of the effects, and this is a quick reflection from some of the work we used we sent out a survey around what has been the effect on the relevant functions. And if you focus on the significant effect part, so we divided it into the immediate effect and expected effect. So in the immediate, most affected what the country most affected campaigns, but also a bit of service delivery and supply chain. There's comments around vaccine procurement. But once you look at the expected vaccines, new vaccine introduction is expected to be affected, campaigns that still be affected, supply chain, service delivery, and so there's an expectation that these are some of the areas we need to keep our eyes on. Now I will skip the slide and what actions countries have taken, and then I will reflect upon them once we have the session. So we did some other work in terms of anticipated level of decline together with the activities of some countries. And again, the percentage decline across the countries varied between 10 to 20%. These are estimates around March. And of course, the situation is global across the country. So this is the percentage change based just on the USG scenario. Now, what will this mean? We use this decline together with the elasticities that have been generated to show the link between that increase in family planning and child mortality, and we see that there will be increase of up to almost 6,000 cases. That's again, based on those preliminary estimates. Of course, as we say, the experience is evolving. So funding cuts will increase BP needs that are already there. Now, in terms of finance divisions, as good that fiscal space analysis done we focused in the countries where the effect, this is Africa, where the effect is expected to be largest, and look at the revenue capacity, the debt status, and fertility capacity to see which of the countries will be most affected. And this was kind of meant to shape how we frame what should the countries do. This was based on all the health sector industry, but we can also put some reflection around immunization. Now, in terms of extent of capacity to expand space, we said most of the countries that are most affected were also fiscally constrained. So I think that's a very important point to note, implying that most of the mitigation that we will efficient with an expectation that the potential for government to increase funding will be very challenging for most of the countries. Now, once we now focus on the EPI program reflections, and again, this brings a bit of discussion previously. This was prepared as part of the discussions we had with the EPI managers at the start of the month. So we know, usually the question we get is, as the EPI, what is our role? Now, based on literature and also what has been done, yes, we know that most of the increases in spending on health are driven by this. And of course, that's not an area which EPI, but also health drives the agenda. Like, we also know that reprioritization is important and analysis from people who did budget. But prioritization is only responsible for only a fifth of the increase. So, in terms of potential to increase budget, given what we have already seen around fiscal space constraints, it will be very important that we focus on the options which we think as EPI potentially. Now, within EPI, we pointed to 3 options and explore the different things. So the first is prioritization within the budget, with the point of where there is some group that's limited in some of the countries. Important focus on programmatic efficiencies. And I think most of the people in the room, PI managers and people involved in programming, I think we have options in this. But also, and as we saw in the last slide, improving spending effectiveness, especially through improving PFM capacities. So those are some of the options. So now in terms of the how, so with regards to increasing government allocation, so first is protecting allocation. We had ideas around ensuring visibility. Even though there's visibility, ensuring there's more allocation, and I think as countries share, we'll be able to see what countries done to ensure some of that is achieved. In the context of EPI, we talk of ensuring that our national immunization strategies are linked to the budgetary frameworks, so there is clear linkage between what we are planning and the allocation we intend to achieve. Strengthening budgetary advocacy, strengthening transparency and accountability, emphasis on sub-national governments, because we know that most of the cuts, especially within the Africa region, again, have affected delivery at the subnational level. So how do we address that issue, especially where we know that it is going to affect the delivery costs? And the other bit is important on how to improve our implementation capacity, especially for financing the Kwesiga. Although we focus on increasing government allocation, we re-emphasize the importance of ODA being important as catalytic, so ensuring that any donor funds that are still available are well aligned in terms of how we use them. Next is the efficiency levels, and I know this also leads to some of the discussion about it. So a big emphasis on strategic procurement. So how do we use our resources better for procurement? Not most of the prepared cost procurement or procurement. The other is on programmatic integration and focusing on functional efficiencies. Again, we talked on some of the things that have been affected. How can we fix some of the challenges there? There's a big discussion I know as we move into 6.0 on F6.0 and delivery channel optimization, so how we improve our delivery strategies, campaign effectiveness. Again, noting that campaigns was an area which we thought, which we saw from the survey that was going to be area. And lastly, again, noting that vaccines are our biggest risk driver. We need to have a big discussion, practical discussion at the company level on how to do vaccine prioritization. So that's the scene setting. I'll hand over to Lola to focus on the next step.
Thanks so much, Brendan. Next, I would like to welcome all of our panelists onto the stage here. Please sit down. So I'm introducing Girmaye Deye. So he's from Fenot Associates and also an health financing advisor to the MOH Ethiopia. Shabana Haidar, she's our country director for ThinkWell in Pakistan. Jalang'o, she's EPI manager for the National Vaccines and Immunization Program in Kenya. And we have Soazic, Elise, Wang from the World Bank. Thanks, everyone. So I think what we wanted to start kick off by is a first question to learn a little bit more about how the US government funding cuts have affected the immunization program in your country. To the panelists.
So it's just reflecting on my eyes. Thank you, Laura. To save your time, quickly start that. So I'm a health economist working for a Fenot project of Harvard School of Public Health in Ethiopia. And part-time I also advise the Minister of Health. And anything I say today is not a political statement, just a little disclaimer. So it's just an expert opinion and experience. So how was Ethiopia affected? So USAID used to fund about, I think, tens of millions of dollars every year on human resource for health, on improving health financing, on digital health, and so on. In addition to all the program areas, including immunization, whatever they have been contributing to that. So a lot of that money, particularly on specific areas like HRH, health financing, I think the latest estimate is about between 4,000 to 5,000 people were unemployed because of that. They were supporting ministries, regional health bureaus, and so on. And so the effect is significant in that sense. The first reaction from the ministry particularly was, okay, what does this mean? Which program areas are going to be affected? How does it affect our basic service delivery and so on? I think the initial reaction was, okay, we're going to be fine. Let's see, until some of the cuts touch actual specific program areas like immunization, and then the next reaction is, okay, what are we going to do about it? So in Ethiopia particularly, it's not just the US government's cut. In July 2024, Ethiopia also started a massive economic reform, which includes devaluation of the birr against the US dollar, tagging or adopting a floating exchange rate, which immediately almost doubled the fund or the resource required for drug and supplies, because the birr was kind of devaluated by half, if you like. So what that means is that in terms of Ethiopian currency, you need almost double the resources you used to need in order to buy the same commodities. So I think your question is that it was significantly affecting Ethiopian health service delivery, but then the government came in and said, okay, let's do some subsidies. And they subsidized, to my knowledge, I think for drug supplies about $100 million immediately after the economic reform. And recently we also did the next fiscal year's budget. If you are in Ethiopia, you are now in 2017. So they just did a 2018 budget. And because of this reform and the US government cut, I think they increased government budget allocation by about 300% to health, especially the federal government allocation. So I think that's a significant move, but I'm not saying everything is good and everything is rosy. I think there's a lot of unknown that is coming in, and they're obviously waiting for the result.
Thank you so much. I'll start with a disclaimer that this is work in progress. Countries are still trying to assess what to do and trying to think. So we don't know, there's no analytical work that has been done, but I can tell you what the countries are thinking. And just to give you a background about Pakistan, so Pakistan is, the EPI program is generally funded by Gavi and other partners. So Gavi is funded by US government, which is the largest bilateral donor after the UK government. And anything that has rolled back for US government cuts has deeply affected all countries, including Pakistan. So the funding of Gavi is primarily, it funds vaccine coverage, it does health system strengthening, sound injection safety, it also provides operational support. With US government funding to CDC, we get technical assistance, especially to WHO and UNICEF. You already know that Pakistan is one of the two countries with Afghanistan which only has polio, so a lot of this financing from Gavi and the Global Polio Eradication Initiative is also funded through Gavi. So just to give you a little bit of context around what the immunization and who are the actors here. So what has changed? So that's the question point what Laura has asked. So prior to this US government withdrawal, Gavi's health system strengthening, equity-based financing, the VPD accelerator, the health system strengthening, and the country technical assistance was programmed for 5 years. Now it has been rolled back to 1 year because we don't know how it looks right now. Gavi also supports routine immunization activities, which is co-finance. So funding restrictions in Gavi, if it is not properly funded by the US government, would mean that you would allow me to use the immunization coverage leading to more and more disease outbreaks. So that's the other thing. On polio, the CDC has withdrawn the $131 million grant to UNICEF for polio campaigns. Also, the CDC funding to global health, integral global health for EPI and global polio eradication has also been stopped. UNICEF also has, the $133 million has been deleted from there. The other point, from the field, the insights from the field are there are a number of HR constraints. So UNICEF and WHO has a role. So UNICEF generally does procurement for us, which is approved procurement at the federal government level because our country is highly devolved with provinces taking lead in health, health planning, health strategy, health service delivery. So UNICEF is the main procurement of vaccines. So if we don't have UNICEF and we do not have that technical support from UNICEF, it would mean that we would also have to rethink and rebuild the capacities that are required for vaccine procurement. So the transition burden also increases if we are not able to co-finance whatever is there. We have a very small kitty. We are spending less than 1% of our GDP on health. And we are in an IMF program. Majority of our monies go to debt servicing and debt financing. So with little physical space, we'll have to prioritize and see where we are. But what does this overall cut mean, not just for Pakistan, but overall? So you could have a resurgence of polio, which has happened. There has been a 344% increase in polio cases in Khyber Pakhtunkhwa, which is one of the provinces bordering Afghanistan. And we also have polio resurgence in other provinces. It would also mean you have outbreak vulnerability for other diseases, and not just polio. You have a service delivery, threat, because the capacities are not there, the support by UNICEF and WHO will not be there. So technical capacity strengthening will also be lacking, because WHO also provides technical capacities, VPD surveillance, all of that stuff. And lastly, we'll have to see and assess how it goes, and as we carry forward the discussion, I will be talking what the country is thinking about. So yes, it definitely affects Pakistan as a whole, because Pakistan also is very high on zero dose, we already know that. So it has a lot to do. Although one of the things that I want to tell you on the national health accounts as per se, the donor financing for the country overall is less than 5%, so we do not get a lot of health financing from donors. It is internally done, but a lot of off-budget support for Pakistan is through donors. And as we talk about the possible solutions, I think one of the important things is to have donor financing on our regular PFM systems. I'll stop here and we give time to some other countries.
Thank you. So I'm going to give the context for Kenya. So in Kenya, we are in a devolved system. So we have the national government and 47 counties in terms of the government structure. And then Gavi is our main donor, but of course they fund the country through other support partners like WHO, UNICEF, PATH, and Clinton Health. So for us, in terms of the effects of USG funding cuts, it is what Brendan was talking about, the unplanned transition. So one, we find ourselves, so first the country was operating on reduced fiscal space. Kenya entered accelerated transition in 2022, and within that same year we doubled our co-financing obligation more than 130% to Gavi. So already we are working in a constrained budget. So for the direct implication of the funding cuts, so at the national level, I'll talk about two levels, at the national level and at the sub-national level. So at the national level, we have TA support. So USAID was giving TA support to different organizations to support the immunization program. So once these funding cuts came into term, we had a lot of layoffs, especially from the partner organizations. So what that basically meant is that the immunization program, which is lean, a lot of activities, is unsupported. And then on the other side, governments has taken a long time in terms of recruitment of staff, and there's been a lot of staff transition. So we have a very busy program that is operated by a very lean staff. Then at the national level, we have the lab services, again, that was funded and supported directly by WHO through USAID, again for the measles rubella lab and also polio lab that had to stop its activities. So it basically means that testing for either polio surveillance and measles has also gone down. At the lower levels, we had partners who were supporting the sub-national level in terms of the counties, in specific things, for example, last mile delivery, support of outreaches, HR. So it means that service delivery at the lower levels has actually been affected. So indirectly, I know US government was heavily supporting TB program, HIV program, and they employed a lot of staff. So we had up to 15,000 staff being laid across the country. So these staff were not only supporting the HIV program, TB program, but there was some sort of integration at the service delivery point. So again, in terms of HR, immunization program has been indirectly affected. So what does this mean for the country? Again, unplanned transition, we're in the process of rethinking how best can now the country look within in the context of reduced fiscal space to see how best to ensure that we do not lose the gains that we've made over the years. So what would that look like in terms of our goals? So it means that we'll start seeing increase in child morbidity and mortality, things that we thought were that have gone to the past. But right now, because of these contextual challenges, we may see resurgence of vaccine-preventable diseases, increase in mortality, again across that population that we do vaccinate. Thank you.
Thank you so much. So I will speak about two countries that I'm most familiar with, which are the Republic of Congo and Sao Tome and Principe. And I have to say that Francophone West African countries have been since less impacted to some extent by the withdrawal of US funds, especially given the colonial ties with the US that is not that strong compared to Anglophone West African country. So in the Republic of Congo, the USAID has been supporting the country disease surveillance and vaccine logistic efforts, and we've seen that, especially during the Mpox outbreak, that there was disruption of service delivery and vaccine surveillance in the country. And the World Bank has been stepping up through like different grants and also investment project financing currently being prepared to strengthen health securities and health surveillance in Congo. And also under our core health system strengthening project, Kobikisa in the country, in Congo, we're planning to do the second demographic and health survey in the country after 20 years, and given the US aid shutdown of the demographic and health survey program, we were not able to complete it as part of this project. So for a country that is actually suffering from a very weak statistical health information system where there's a lack of data for evidence-based policy making, this has been quite an important challenges. And I'll probably talk a little bit more about how the bank is then preparing, even though historically external funding as a share of current health expenditure in Congo has been 11%, and that the US government is only less than 1% of total domestic assistance for health. We are ramping up our technical assistance to ensure that the country really tap into potential domestic research mobilization options to be prepared for the retrenchment of more technical and financial partners. In Sao Tome and Principe, the US government has also been supporting vaccination efforts under the COVID-19 project. And there as well, as I say, even though external financing as a share of foreign health expenditure is quite high, because the country is heavily dependent on donors, the US government doesn't have more of a share on domestic assistance for health. Although the USAID was supporting, as I say, the COVID-19 vaccination effort, and the World Bank has been stepping up its engagement under the COVID-19 emergency response project to kind of support those countries in cold chain equipment and vaccine logistics as well. So we are also, and as I presented earlier, kind of helping the country to with Gavi through targeted country assistance to be prepared to the retrenchment of more partners that have been supporting the sectors historically.
Thanks. So for the experiences I mostly share from the Eastern Southern Africa region, and also from the country survey. So we had two sets of actions. So there's actions to increase spending. While I shared that most of the countries were fiscally constrained, we saw very surprising actions. So for instance, Uganda doubled its health budget, the entire budget. Of course, the potential for EPI to leverage from that double is what we look for. In fact, from Ethiopia, they have increased by 300% the federal budget. So, and Tanzania was also taking a similar action in terms of using this crisis as an opportunity to engage with parliament and say this is the government we have. Because most of the countries, at least were able to generate some numbers. I know Kenya had a plan to show this is the issue, this is the level of cut, and this is what it gets better than it. So I see that as a positive action in terms of ability to drive relocation discussions, even when the empirics were not saying it's possible. Now, in terms of other actions, we saw actions to cut costs, because some of these programs were already being funded by donors. So from the country survey, we saw some contracts and the CS for instance were cancelled. Some outreaches had to be cancelled, and a number of countries actually, like a big proportion of their coverage use outreach. So these actions to cut costs are not just saying we are saving, because they are actually now distracting the regulation. So while there's the positive action in terms of countries being able to drive a discussion around relocation, and of course remember saying we have allocated twice the budget that is translated to this part. So that's why I'm not necessarily very optimistic even with the positive action. So why we have seen increase in allocation because of the action in terms of disbursements, but then you know that this cutting process going was affect the program performance, and I think that's something to watch out for the coming
Thanks. So our next question would then be, so given all of these challenges that you have laid out, what are the funding levers that have been used to fill some of these gaps? So funding sources, maybe innovative financing models, and then assuming that not all gaps could be filled, how has prioritization taken place?
Nominated start by so I think the issue around what levers countries are using, and again, noting this is early experience. So a lot of these effects are at subnational level. Because for sure some of the countries have already most of the countries have already procured vaccines, so it's about how do the vaccines get delivered, how do the vaccines, how do the services get provided. So a lot of this is how to then try and leverage some of the subnational level financing sources. So we know there has always been some money at the facilities where it's able to flow, some money is within the subnational governments. So one of the discussions that countries have had is how to ensure that these subnational governments are able to pay for the service delivery at that level, especially in the developed settings where they have decision making power. So that's one of the levers that is being pushed. The other one, which I did refer to, but I'm not very optimistic about how realistic it will be, is the integration option. Why it is being discussed in countries as one of the good levers to try and really cover the costs. We know that even with, as the example was given, the USG funding was already supporting health workers who are actually supporting these other programs. So while we say we are going to integrate and improve performance, I see it more from potentially we are cutting because the allocation was not enough anyway. So if we're not going to hire more, we say we're integrating, we may even be further disrupting the resource. So the options around trying to pull as much resources within the health sector from especially the subnational level, I think it's a good innovation that will work. But also if we're able to add more resources, then you can actually have more realistic integration.
All right, thank you. I think just to continue from that, in Ethiopia as well, the subnational levels also started mobilizing more resources. Ethiopia is kind of a federated system, and therefore the effect of these cuts would affect subnational levels more immediately. And they understand the magnitude of the problem, and they've started mobilizing their own resources, and some of the regions have started even talking to some donors, co-financing from their own regional funding, and so on. And even at federal level, one of the things they did was, okay, US government decided to cut their support, and they said we thank them very much for supporting Ethiopian health system for so long, but they have no obligation to continue funding us, and therefore they started, if you like, diversifying donors. So maybe you've heard about the UAE $500 million support for family planning and so on, and for Africa, and so Ethiopia is one of the negotiators. So they kind of started talking to different donors to see, okay, at least in the short term, is there a way you can fill the gap? And then we will get prepared, not ready. So those were kind of, if you consider innovative, those are some of the things they did. I think to get back to my first point, I think the biggest impact was, I would almost say this is a blessing in disguise in a sense, because for the health system particularly, it was not easy to talk to the finance system to kind of reprioritize health prior to this cut. And now all of a sudden, health has become such a political agenda. It becomes much easier for the Ministry of Health to go to the Ministry of Finance and say, look, what's happening? We've been telling you this for long, that health is not being prioritized. And now that our donors, our supporters are now kind of cutting back, therefore it's time for you to pitch in. And so it became a political agenda in a way. That's why I call it a blessing in disguise in a way. So those are some of the things. I think that in terms of the big lessons, I would say Ethiopia is kind of unique. I think every country is unique in a sense because we don't have any kind of colonial relationship with anybody in that sense. So that kind of neutrality comes with all advantages and disadvantages. So we had to design our system, from the bottom up. And so when something happens internally and when there's a political change or so, donors always, they tend to think, okay, should we continue funding or should we stop? And we've been having those lessons in the past several years. So it didn't come as a surprise. There was always discussion about being prepared, preparedness and so on. So that happened in a sense. I think one big lesson is that Ethiopia kind of based a lot of its essential health services, including immunization, HIV/AIDS, malaria, maternal health, and so on the donor support. So about 2/3 of the commodities for this program areas came from donors, at least. And so the lesson is, I don't think you should base your essential health services on donor support. And I think you should fund your essential services from domestic financing and take whatever donor gives you for additional stuff. So if they come, it's good, it's a bonus. If they don't, then you still rattles.
So I'll start by saying that we don't need to build we need to build 8 exit ramps, but not 8 highways. And I think it's a wake-up call, as my colleague said. It was a jolt. I think the way it was done was not proper, but I think it gives the countries insights that they need to be very serious. And regarding Pakistan, what they're thinking and how they're filling gaps for now, I think they're taking a lot of ownership on themselves, and the monies that the government share of financing in 2016, I believe, was 1.5% at that point in time, and now in 2023, it's surpassed Gavi. It's around 45 or 50%. So there's a lot of ownership. What the provinces are doing are protecting lines for immunization in their own budgets. So that's very healthy and that's very positive. So they recognize the fact that they have to fund it by hook or by crook. They have to find that space. And since I look at health financing of the country with the provinces, I think there's a lot of space. If I just mention one of the provinces, about 65% of the budgets were spent overall in health, 35% were unspent, which would have funded immunization or medicine availability for the next year. So there's a lot of space in the system. I think we need to be very, very cognizant of the fact of how, looking at the efficiencies of how much we are spending, how effective we are spending, and try to find those monies for immunization per se. The second thing that we're doing is we're also looking at a rationalization of new vaccines. The federal government is planning optimization and prioritization workshop, optimization of the already vaccines that are there to see how efficiencies could be built in, and the rationalization of any new vaccines. We are currently going to launch the HPV vaccine with different stages in different provinces, but I think there is a chance of how to capitalize on efficiencies there. I'll just give you a small example. The routine immunization is one silo, and the GBEI, which is the polio eradication, is another silo. They work through the whole systems. There are different touch points with similar touch points with similar personnel, but very different silos. I think the government realizes it, and there are talks. I'm not saying it's happening right now. I don't want the Gabbies and the Gates Foundation to come and sue me. I'm just saying that there is a thinking of getting them together because this is for the efficiency to happen. We're also looking on diversifying of donors, so minus US. We're looking into the Islamic Development Bank. We're looking at Saudi Arabia. We're very good friends with China. So whether we are looking for monies or we are looking for technology transfer is something different, because I think there is high time for health diplomacy and vaccine diplomacy, because we don't use vaccines like India does. But there is a room for this vaccine diplomacy to happen, which was not happening earlier on. And lastly, we're also looking into different innovative financing models, especially working through PPPs and having good PPP, structured arrangements for different things. So we're just thinking, we're in the thought process. Some of the things have actually transpired. As I said, the budgets have increased. Some of the provinces are also planning, so there are strategic plans being built up. There's also talks of transition planning. For example, the Global Fund is planning transition planning for Pakistan for malaria, HIV, and tuberculosis, because it's also heavy on US government funding. And similarly, that needs to happen for Pakistan for immunization. And I think this is the right time. We know that the Gates or the Gabbies would withdraw support 2031. I don't hope them to cut the funding right now, because that would mean a setback to the polio program, which is currently going on in Pakistan. But we need to have transition planning in process. I am not saying bypassing the donors altogether. They have their own value for accountability, for technical assistance, for visibility, but they have to work under a certain framework. I'll stop here, maybe something to say.
All right, thank you. So for Kenya, what are we doing? So within the few couple of days after the USG funding cut, the Ministry of Health coordinated to assess the impact of the funding cut. So we had sort of short-term goal, mid-term goal, and also long-term goal in terms of the next steps the country is going to take. So in terms of the short-term goals, we looked how we can leverage on innovation to be able to bridge the short term, and then the longer term objectives, and the mid-term and longer term objectives, which stakeholders we are going to bring on board. So some of the things that we are thinking about in terms of the short term, we've had non-traditional actors or partners who've not supported immunization program before come to support the program, and then also leverage on public-private partnerships in terms of those institutions that you were not thinking before coming to support the program in order to address the short-term gaps. And then working within the health system to see how best to do strategic partnerships with either HIV, TB programs, malaria programs, to leverage on things that initially were being done in silos, and how best to strengthen the health system. So the thing that we've learned about the funding cuts, again, based on what happened recently, is that any donor who wants to support the country, the government has to really look how is the support to the country, are they leveraging on the existing systems, and then what is the sustainability plan? Because unfortunately, some of the programs that are being supported by partners, after the funding cuts, it means that they came to an end. So again, which is a wasted opportunity, especially for the investments that were done in the country in terms of the human resource and also the time. So one lesson that we learned from that is that any innovation, any partner coming to work with the country has to really think how best this can be sustained, even post the donor support.
Sure. Thank you so much. So from a World Bank perspective, we've been providing, we've been ramping up our targeted technical assistance to countries that have been under Gavi Accelerated Transition Phase. So we've been working hand in hand with other technical and financial partners, UNICEF, WHO, to first help this country finalizing their health financing strategy and immunization strategy. So we've been doing it in Congo, for instance, where thanks to the range of analytical studies that have been presented, the fiscal space analysis that are presented this morning, but also costing exercise and immunization financing system assessment, we've been really supporting the country to have this very first health and immunization financing strategy. And as I speak, under the core health system strengthening project of the country, we've been also trying to conduct public expenditure tracking survey for immunization and health funding to identify potential bottlenecks in public financial management systems. So the country can actually identify potential leakages that are happening throughout the funds, the flow of funds directed to frontline healthcare facilities. So that's the case of Congo. In Sao Tome and Principe, we've also been doing the same. So thanks to the World Bank support in terms of targeted country assistance, we've been also supporting the country finalizing the very first health financing strategy that was unveiled early this month on July 4th. And at the same time, we also, through the COVID-19 project, providing additional financing for the country to strengthen its vaccine deployment infrastructure and disease surveillance. Financially speaking, the World Bank has been fast-tracked the approval of new projects to kind of bridge the gap that is potentially being left by the US withdrawal. So across the West and Central African project, the West and Central African region, we've been having a new project, health security surveillance project that will then also support EPI, expanded program of immunization in each countries, but also help those countries to improve their cold chain and vaccine infrastructure throughout the years. So, but I would say we are putting more emphasis right now on ramping up our target and finalizing the ongoing technical assistance that are being provided thanks to Gavi support, making sure that those countries have proper strategies that they can lay upon and tap into the potential options that have more impact to generate physical space and resources over the next 5 years.
Thanks. So I would have had a million more questions, and I'm sure everyone in the audience as well, but unfortunately we really have to move on to the next session. So I just want to thank all of the panelists for these great reflections and hand it over to... Thanks so much. So then I want to hand it over to Nafrit Singh from Chai, who will be moderating the next session. Thank you.